Next, we have Aaminah Verity, who is a GP in Lewisham and PCN Health Inequalities lead. She's previously worked with homeless communities at Pathways and other BCSE organisations and is working on a programme locally to tackle health inequalities and support community development. So over to you, Aaminah.
Hi everyone, thank you so much for having me, and thanks for a great presentation, Nick and Dan. I have to say, Nick, I hadn't heard of your department before and your role. I apologise, but I'm very encouraged by everything that you said, and hopefully you can see that our approach is ticking a few of those ideas in practice. So it'd be great to link with you at a certain point to see you know, the practicalities of what we've had barriers with. So next slide, please. So as Hannah said, I work in North Lewisham, so similar to kind of Dan's picture of Tower Hamlets. We're a central London vibrant community. We represent 9 GP practices, so we're quite a large PCN, and we're 80,000 population. And but along with that, we've got, you know, our PCN has the worst outcomes for Lewisham. So our life expectancy, male life expectancy is the lowest for Lewisham at 75, compared to 2 miles down the road, 81 in Blackheath. Next slide, please. So we started thinking about health inequalities and North Lewisham back in sort of May 2020 during the first lockdown, and we looked at kind of talking to we were really worried about how remote consulting and the move to kind of total triage had impacted kind of care for our local population, specifically focusing on vulnerable communities. And so we were doing a program of work looking at how we could improve some engagement with how we could change GP access, improve GP access for those populations. And we were working with some community organisations looking at that. And that was the point at which we kind of I branded myself as the health inequalities lead, and the PCN started paying me as such. And shortly after that, whilst we were kind of doing this community engagement work, thinking about GP access, how we could improve it, specifically kind of focusing on inclusion health groups, the COVID vaccine started rolling out in kind of December time. And then by March 2021, we saw that kind of expectedly, as per all North Lewisham kind of metrics, we were the worst in Lewisham. And so we had 34% uptake of eligible patients had a COVID vaccine, compared to kind of 86% of our white residents. And so we were asked by the CCG to think about what was going on, and I'd branded myself the health inequalities lead at that point. So they were like, okay, this is a health inequality, what are you going to do about it? So we rapidly mapped another 115 organisations looking locally, and we contacted them using some volunteers, retired GPs, some COVID champions, and we talked to them about what they felt the causes of poor vaccine uptake and health inequalities were. And these 3 key themes came up, which, you know, I think Dan gave a really good overview of where these things come from, but of the social determinants of health. So lack of trust was a key thing, and that included things like systemic racism and people's experience previously of the healthcare system, barriers to care, which were things around digital exclusion, difficulties booking vaccines, and also navigating the GP system and struggling to register if they didn't have ID or proof of address. And then this broad thing of which we're calling poverty, but essentially the social determinants of health. So very similar to the Tower Hamlets statistics, we have 3/4 of our population are in IMD decile 1 or 2, so the lowest IMD deciles. Next slide, please. So we started working with those kind of 32 organisations that were actively involved with us, and doing kind of co-production workshops around what could we do about it. And we focused on a few things which I'm going to talk you through. So the first thing we looked at, if you go to the next slide, was how we could improve COVID vaccine uptake. And as Dan said, we had that lower super output area kind of data where we could see really specifically individual areas that had really poor uptake. and they were very closely mapped to deprivation, high proportion of ethnic minority residents, and we found really, really low areas of vaccine uptake. We identified community organisations that had a good, also apologies if you can hear my toddler screaming in the background, he's with his dad. We identified community organisations that were embedded in those areas, working well with the community and, you know, well trusted and well liked. We approached them and gave them participatory funding grants, really small pots of £500, and said, we want to work with you. We want you to help us to run COVID vaccine pop-up clinics, but we want you to be in charge of the engagement strategy. So we gave their volunteers £30 to attend some training with us, where we taught them about the COVID vaccine and we taught them how to have conversations with people around it. And then we let the communities do what they wanted to do around community engagement. So some people went door-to-door knocking and dropped flyers. Some people went and spoke at the school gates to mums. Some people did some barbershop and hair salon things. And it was up to the individual organisations that we work with, how they chose to engage their communities. And we gave, you know, there was no requirement from our side as to what we would expect or didn't expect. And then we helped the community to run their own pop-up vaccine clinics. So if you go to the next slide, please. You can see these are two completely different approaches from two completely different community organisations. One is a community garden, and theirs was very focused on, you know, sow a seed on your first jab and come home and take a plant home on your second jab. And we had, you know, some not huge numbers of patients coming forward, but I think the big difference was from other pop-up clinics that were happening at the time was that we were targeting the patients that we wanted to see. So it was older, ethnic minority. We had a really large number of undocumented migrants coming. Around 55 Deliveroo and like Just Eat drivers turned up, who none of whom were registered with a GP and got their vaccine. So it kind of highlighted to us the approach of kind of giving the community ownership of things and supporting them to provide us being an adjunct and letting the community lead, that it really proved that model for us. So next slide, please. Part of the work that we were talking about at the time was what are some of the barriers to access to care, and one thing that we kept hearing consistently was that people felt that general practice was really impenetrable, that it was really difficult for a community organisation, say for example a food bank, to contact a GP surgery and say, I'm worried about this patient, can you help? Or I'm really worried about this client. And also that there was just this complete loss of the GP practices being part of their community, and they didn't feel like we were part of that. So they talked about having someone like a community link worker that was this central point of contact to act as a bridge between the GP practices and the communities. And I'm sure many people here have employed community social prescribing community link workers in this way. And we were really lucky to find Joyce, who had done 25 years of community development for various charitable VCSE organisations, and she chose to come and work for the PCN. And she helped us to develop the community forum, which was another community design thing. If you go to the next slide. So the idea of this was basically that, so we were aware that there were lots of other forums, but multiple times in multiple design sessions, people were saying, no, we really think there is a need for a central space for it to just be around health inequalities. And that's the place where you will keep coming back to us and letting us know what's going on and what's happening next. And we were really lucky to get some support for Time for Care, which I don't know if people know, but it's a branch of the NHS England improvement thing, and they basically taught us kind of a bit more about how to run a meeting and get good outputs out of it, how to use a Jamboard, how to think about things like, I don't know if you can see in the top right that we had a talking wall, which was the idea that if at any point anybody wanted to, they could walk over and put a post-it note on. And we made sure that it was a hybrid model, so we were targeting people who were both, you know, still worried about coming meeting face to face, but also we wanted to ensure that there was a non-digital, we weren't being digitally exclusive, and it was about coming together to identify the priorities. And the other big thing that Joyce has taught me is you can't put on a community event without some food and some kind of entertainment. So I don't know if you can see in the top left, but we had some traditional quadrille dancing happening at the Christmas forum, we had some local community musicians come and do a little bit, and we always have the idea is that it's a rotating community venue, so we drive the local organisation, we drive a bit of the local economy by allowing the local organisations to choose someone to cater the event. And although it's a small amount of money, it does provide some kind of publicity and, you know, give that person opportunity to cater a large NHS funded event. So move to the next slide, please. And someone's put in the chat, it was Time for Care. Yeah, that was the name of the organisation that helped. And so this is an example. We also always hire a visual minutes artist. And this is an example of our last forum, which was in March. Just because we decided that, you know, so many of our residents don't speak English. We know literacy levels are low in Lewisham. And so we wanted to have a fun, easy visual representation of what we talked about and that we can share with the community for those who don't attend on the day. Next slide, please. So some of the outputs of the community forum. So the first forum focused a lot on improving access to GP care, and I'll talk to you a bit more about that in detail in a second. But the other thing was that poverty was the community's #1 priority. And I remember thinking at the end of the first forum, like, what are we going to do about poverty? We're a bunch of GPs. Well, we're actually 3 GPs and representing the PCN. We can't do anything about this. This is a nightmare. We're going to have this poverty working group and I'm just going to have to tell everyone we can't do anything. But actually, when we had this first poverty working group after the first forum, and essentially what came out of it was this idea that the community really needed to hear that general practice and the healthcare system understood that the social determinants of health were the reason that people were sick and ill. And we basically just wrote it down in this strategic vision, which said that we accept that the social determinants of health are a thing, that we accept that systemic racism is a thing, and that we are going to try and work with the community side by side to try and think about how we can change that going forward. And I think that's kind of looping back around to kind of the very first thing, which is it's about trust and building back that trust, that actually we're not here to just do that 10% of things that in Dan's first talk, the 10% of healthcare, that we are here to advocate for you on your behalf and stand with you because we're all part of the same community. So moving on to how we improved access to GP care. So we did some co-designed messaging. So a lot of the discussions we had was that the community felt that they just didn't understand the changes that had happened with COVID, and all of the move to kind of digital first and triage first models had really left a lot of people behind. So we've co-designed some booklets and pamphlets to explain how to access care, and also something around choosing well and all of the services that you can access before you come to the GP. And then I'm going to take you through our care coordinator work in a bit more detail. So the other thing was that, okay, so we were trying to improve GP access, and we had looked inwards and we'd done kind of the safe surgeries training again with some of the practices, but practically what we kept hearing from community organisations is, well, we try to register someone there and then they say no, and then we go to another practice and we go to another practice and we just go round and round and round, and it's really difficult. And so what we decided was that what we needed was a direct route into for the community to say, I am struggling, and now the care coordination team can pick you up and say, okay, let's sort you out and let's get you into care. And so essentially we have like an email address, a phone number, and someone who has a physical presence in our health centre, which you can see in the back, where there are 3 GP surgeries of our 9 are based in that building. And they basically they can accept referrals from anyone. They can accept referrals from the GP, from community organisations, and from the social prescribers. And the idea is that they so say, for example, you have a food bank who said, I've got an undocumented migrant who I can't register. They can now refer to the care coordination team, and the care coordination team can directly liaise with the practice where they failed to be registered, talk to the practice manager. They have the bypass numbers. They are PCN staff, and they can navigate through that that difficulty that a lot of community organisations and individuals struggle with. The other thing is that we've created these kind of referral templates for GPs to say to us, okay, I've got someone who, you know, I sent off to go get an ECG, some blood tests and this and that, and I've not heard from them and it's been 6 weeks. And then when I spoke to them, they said, I don't know how to do it or I can't navigate it. Actually, can the care coordination team build the skills with that patient to try and help enable them to think about how they can navigate through healthcare? And it's trying to take away trying to identify what is different. So the way we've thought about it, and again, this may be different to how other people have thought about it here, is that the social prescribers are kind of for signposting and navigating everything outside of your healthcare, but we're trying to get the care coordinators to focus inwards on the healthcare system, and at the moment how challenging that is for individual patients. And it's kind of really exacerbating that thing of people hitting a kind of revolving door, and so trying to stop that spiral and make sure that we get the right people in and we support them. So we've also partnered with Groundswell, who provide this homeless health peer advocate program. And this is something that they do at a CCG wide footprint usually, but we've asked them to do it for the first time at a PCN footprint using the R's budget. And so this is someone with lived experience of homelessness who does direct support with individual patients to help literally accompany them to appointments. So these are people who are really at the very sharp end of health inequalities and thinking about the most vulnerable patients. But we don't want to focus just on homelessness, which is what Groundswell has previously done. We want to allow GP practices via this care coordination team to say, actually, I have a housed patient, but they're incredibly vulnerable. I've got a patient who's blind, uses heroin, is a type 1 diabetic, and, you know, has a necrotic foot but doesn't engage with care, and she's a perfect one that once we've got this inclusion healthcare coordinator, we want to get them underway. So we're interviewing with Groundswell next week for that, which is really exciting. Next slide, please. So I'm going to whiz through this. I'm sorry if I'm going really over time, but the other thing that we looked at was essentially a data strategy, which was how do we identify those who are at risk of health inequalities. So we collected 300 EMIS codes, which were linked to the Pathway Homeless Health template, and basically that kind of represented the inclusion health groups. And then we worked with the population health team to add in lowest socioeconomic status, so lowest IMD deciles and ethnic minority, and the idea is that it pops up and it says possible risk of health inequalities. You double click on it and it shows you why the code has like alerted, and then you agree as a clinician, yes or no, this person is at risk of health inequalities, and it allows there to be a red dot saying health inequality identified, which means that under our triage models you can actually see patients, you can make sure that you're not turning away vulnerable patients to the first contact physio, when actually what you want is the homeless patient with the back pain to be seen by a GP, because that holistic assessment has to happen. Next slide, please. And we use that cohort of patients to basically have a look at whether or not we could do prioritized health checks. And so we got our care coordination team trained up to do health checks, including point of care blood testing. And just for this pilot, we looked at doing all over 18 plus, anyone who was identified as at risk of health inequalities by this tool, just to see what happened. And number one, by care coordinators calling patients with a translator, explaining what a health check was, we had a 70% uptake rate of the invite compared to 20% from a text message from the practice normally, and 80% of those patients came on the day, which is really great DNA rate. And then the really shocking thing is, though, so normally for a health check, you'd be expected to pick up one patient for every 100 health checks that you do who'd be at risk of long-term health conditions. And 60% of our patients were found to have one abnormality, and 40% of them were under 40 years old, really showing that actually for this population, the NHS health check starting at age 45 is too late. And I think Dan made that point really clearly earlier. And you can see these are not small things. So fine, the majority of the referrals were for obesity, but actually there were 5 people at risk of who had high blood pressures that needed follow-up. There were 6 patients that were pre-diabetic, 1 patient was diabetic, people with really high Q risk scores. And we've started doing this for the PCN on a much wider scale for each practice with their health inequalities population. And every single clinic with a GP lead, we are finding patients with uncontrolled hypertension, new diagnosis of diabetes, a patient with hypertriglyceridemia, so worrying that they are at risk of severe pancreatitis and they've had an urgent referral to the lipid clinic. So it's really picking up these patients and proactively identifying and targeting our work and reaching out to those populations, similar to what Nick was asking before. Next slide, please. So we've reached the end.
Sorry, I was just going to say, this is so interesting, but we're really running out of time. So
okay, sorry, I'll stop. Yeah, basically that's our model, is community-led, collaborative, prioritized. So I think the key thing, if you move to the last slide, actually, I think that's probably, yeah. So I think the key thing is the reason we've been able to do this work is having a lead, paying them to do the work. I wouldn't be doing this if I wasn't being paid. Getting support from other organizations. So in my slide pack, I've put a few things like Fair Health Pathway, other people who've really helped us to think about the health inequalities needs of our PCN, and then using the resource that you have, so using the R's roles and making it a core target, making it the core of kind of your PCN work.